Hey everyone, and welcome back. We're really excited about today's conversation. Just a quick note before we dive in, this episode is adapted from a clinician-written article on Mentalyc and brought to life in audio for therapists who prefer listening on the go.
That's right. And this particular piece was written by Adeswa Olajire, LCP, and we're just so happy to be able to feature their perspective here today.
Absolutely. And since the article comes from Mentalyc, it might help to know it's a clinical intelligence platform really designed to make our lives, specifically around documentation, a whole lot more manageable.
You know, that just immediately makes me think of that Sunday night feeling, that specific kind of dread when you know you have a mountain of progress notes to get through before Monday morning hits. It's that feeling of being tethered to the keyboard instead of reflecting on the actual work.
Oh, I know that feeling intimately. It's like the ghost of documentation, past, present, and future, all haunting you at once. And it's so interesting because when you look back at the history of how we've documented our work, that feeling, it's not new. It's just taken on different forms.
Right? It wasn't always about login credentials and server errors. It used to be about finding the right paper file in a giant teetering cabinet or trying to decipher someone else's handwriting. The core challenge has always been there. How do we capture the essence of a human story in a structured way?
Exactly. And the journey is honestly wild. I mean, we're talking about a history that goes back millennia. The earliest forms of this were literally Sumerian clay tablets from 2400 BCE. Can you imagine chiseling a soap note into a block of clay?
Oh my gosh, no! Client presents with, uh-oh, I made a typo. You'd need a whole new tablet. And then there was the Ebers Papyrus in Egypt around 1500 BCE with medical recommendations. It's fascinating to think that the fundamental drive to record, to remember, to pass on knowledge is so ancient.
It really is. It wasn't just about record keeping for the sake of it. It was about continuity of care, even back then. And then you have Hippocrates in ancient Greece, who was known for keeping these incredibly detailed case notes. He was codifying treatments, trying to find patterns. He was the original clinical data scientist, in a way.
And that's a great way to put it. He was looking for the why. It wasn't just client felt sad, it was client felt sad after this event, and this is what we tried, and this was the outcome. But for centuries, that was pretty much an individual effort, right? A practitioner's personal notes.
Totally. The big shift towards standardization really started to happen much, much later. In the 18th century, there was this German physician, Johann Theodor Eller, who introduced the idea of daily patient observations at a hospital in Berlin. He basically made it mandatory for doctors to document clients' illnesses and their treatment history. It was a move from personal diary to a formal hospital record.
And that makes sense. Once you have more people involved in a client's care, you can't just rely on one person's memory. And then, of course, the big driver was money. Isn't it always? The rise of social health insurance meant there had to be a standardized way to track care for billing and legal reasons.
It's always the money and the lawyers. That's what really pushed the need for clear, organized, and defensible records. The vulnerability of paper was a huge issue. Fires, floods, misfiling, theft. A client's entire history could just vanish.
I've heard horror stories from supervisors who started in the paper era. Entire filing cabinets getting lost in an office move. Or the sheer panic of realizing a crucial file was checked out by another clinician and you have no idea where it is. We complain about our systems now, but the physical insecurity of paper was a whole other level of anxiety.
Right? So that brings us to the 1960s, the dawn of the computer age. This is where the first attempts at computer-based records started, and they were a start. We're talking about data storage on punch cards. It was expensive, incredibly clunky, and not very useful for actual clinical work.
Punch cards. It sounds so archaic. It was probably more work to punch the card than to just write the note by hand. But you have to admire the vision. Someone saw the potential, even if the technology wasn't there yet.
Exactly. And then a huge breakthrough came in 1968 from Dr. Larry Weed. He developed something called the Problem-Oriented Medical Record, or POM. This was a major conceptual shift. It moved the focus from just a chronological diary of events to a structured system organized around the client's specific problems. It's the foundation for the SOAP notes and the structured notes we use today.
That's a key distinction. It's not just a record of what happened, it's a record of what we are working on. That's a fundamentally therapeutic way of thinking. It aligns the documentation with the clinical process itself. And pioneering institutions started to run with this. You had places like the Mayo Clinic and Lockheed, of all places, building these early clinical health information systems.
And you can't talk about early EHRs without mentioning the VA. Around 1972, they developed their own system, which eventually became VistA, the Veterans Health Information Systems and Technology Architecture. It was, and still is, a massive and incredibly comprehensive system. The VA was light years ahead of the private sector, largely because they had a closed system and a huge population to manage.
That makes sense. They had the scale and the incentive to build something integrated. For a long time in private practice, it was still a total Wild West. Everyone had their own system or no system at all. And the cost was just prohibitive for a small practice.
Completely prohibitive. But then came the 90s and the 2000s. The internet became more widespread, computers got cheaper, and suddenly the idea of a digital record wasn't so far-fetched. And then came the big one. In 1996, we got HIPAA.
HIPAA. The word that strikes fear and respect into the heart of every clinician. And it's so crucial. It forced a conversation about standardization, but more importantly, about privacy and security. It basically said, if you're going to do this digitally, you have to do it safely.
Precisely. It set the ground rules. Then, in 2004, the Office of the National Coordinator for Health Information Technology, the ONC, was founded. President George W. Bush really championed this, pushing for widespread EHR adoption. And you can see the numbers. In 2007, about 35% of office-based doctors had an EHR. By 2017, that number had jumped to nearly 86%.
Wow. That is a staggering jump in just a decade. What was the catalyst for that massive leap? Was it just the ONC?
It was the HITECH Act of 2009. This was the real rocket fuel. It was part of the American Recovery and Reinvestment Act, and it allocated billions of dollars to encourage healthcare providers to adopt certified EHR technology. It created the Meaningful Use Initiative.
Meaningful use. I have such a complicated relationship with that phrase. On one hand, it provided financial incentives, which was the push everyone needed. On the other hand, it felt like this mad dash to adopt any certified EHR, whether it was good, intuitive, or even appropriate for your practice, just to get the incentive money.
Yes, that's the key frustration, isn't it? The policy was well-intentioned: improve care, create interoperability, digitize records. But the execution led to this explosion of clunky, poorly designed systems that were often built for billing first and clinical care a distant second. They weren't designed with a therapist's workflow in mind.
Not at all. They were designed for medical doctors charting physical symptoms. So you'd end up with these drop-down menus and required fields that made no sense for a therapy session. You're trying to capture the nuance of a complex relational dynamic, and the system is asking you to check a box for wheezing. It created so much administrative burden. The time spent clicking boxes and navigating confusing interfaces is time not spent with clients, not spent reflecting, not spent doing the actual work.
It's the cognitive fatigue, the alert fatigue. You get so many pop-ups and notifications that you just start clicking X on everything without even reading it. And that time we spend wrestling with the EHR, it's often unaccounted for. It's the work we do after work. It's the reason for that Sunday night dread. It's a direct line to burnout for so many of us.
Absolutely. The shift to EHRs, while necessary, has had this unintended consequence of increasing workload and stress for many clinicians, especially those of us in mental health with larger caseloads. The promise was efficiency, but for a long time, the reality felt like the opposite. You're just feeding the machine.
A quick pause here. If this part of the work, that feeling of being bogged down by documentation, feels familiar, Mentalyc can really help. Its AI note-taker supports your documentation and your clinical judgment, all while staying fully HIPAA and SOC 2 compliant. You can explore it at Mentalyc.com.
That's such a relevant point to bring up right here because the burnout is real. But the story doesn't end with clunky systems and frustration. The technology has continued to evolve, thank goodness. Modern EHRs are starting to get smarter. They're starting to incorporate features that actually help us.
They are. We're seeing more adaptable note templates, more intuitive user interfaces, and better integration with things like telehealth platforms, which became absolutely essential overnight a few years ago. And the big word now is interoperability.
Interoperability. It sounds like technical jargon, but what it means in practice is so incredibly important for client care. It's the dream of a client's information being able to move seamlessly and securely between their primary care doctor, their psychiatrist, and their therapist. No more faxing records, no more clients having to repeat their entire trauma history to every single new provider.
Exactly. And there are real standards being developed to make this happen, like HL7 FHIR, which stands for Fast Healthcare Interoperability Resources, and legislation like the 21st Century Cures Act is pushing for this, mandating that systems have to be able to share data without putting up information blocking barriers. It's about putting the client story back at the center and making that story portable.
And part of that is also about client access. The rise of client portals has been a game changer. It empowers clients to participate in their own healthcare. They can see their appointments, read their session notes, if you share them, and use secure messaging to ask questions. It demystifies the process and can really strengthen the therapeutic alliance.
I agree. It changes the dynamic from a hierarchical one to a more collaborative partnership. When clients can see their own progress, track their own goals, they become more engaged. But the biggest change on the horizon, the one that's really set to transform everything we've been talking about, is artificial intelligence.
AI. That's another one of those words that can bring up a lot of feelings for clinicians. There's excitement, but there's also a lot of apprehension. The immediate fear is a robot going to take my job? Is it going to try to diagnose my clients?
That's the knee-jerk reaction for sure, and it's a valid concern to have. But I think it's crucial to reframe it. AI isn't here to replace our clinical judgment. It's here to augment it. It's about automating the tasks that drain our time and energy so we can focus more on the deeply human work of therapy.
So it's not about replacing the therapist, but about replacing the tedious administrative burdens that lead to burnout, like documentation.
Exactly like documentation. This is where tools like Mentalyc come in. It's an AI-powered documentation tool built specifically for us, for mental health practitioners. It's designed to take the raw, unstructured data of a therapy session and help you create a structured, compliant progress note or intake note, faster and easier. It's not telling you what to think. It's giving you a really good first draft.
A first draft. I like that, because the blank page is often the hardest part. Staring at a blank note template after a long day of sessions can feel impossible. Having something to react to edit, to refine with my own clinical perspective, that doesn't feel threatening. That feels like support. It feels like a smart assistant.
That's the goal. And the integration is getting so much smarter. The article mentions this, and I think it's a huge deal. The ability to transfer your notes to your main EHR with a single click. No more copy-pasting.
Wait, seriously? That alone, that right there would save me so much time and so many headaches. The number of times I've had to copy from one window, paste into another, reformat the text, realize it didn't copy correctly, it's maddening. To eliminate that one little step is actually a massive quality of life improvement.
It is. It's one of those small things that has a huge cumulative effect on your day and your stress level. And beyond just documentation, AI has the potential to help us with data analysis in a way that's clinically meaningful. Imagine being able to see trends in a client's language over time, or track progress on treatment plan goals more objectively. It's about getting deeper insights from the data we're already collecting.
That's really powerful. But what about the ethical concerns? Data privacy is paramount. And what about algorithmic bias? If an AI is trained on a certain data set, could it perpetuate biases in how it interprets information?
Those are absolutely the right questions to be asking, and they are non-negotiable. Any responsible AI tool in our field has to be built on a foundation of security and privacy. That means HIPAA compliance, SOC 2 compliance, all of it. And the bias issue is real and requires constant vigilance, transparency, and a commitment to training models on diverse and representative data. This is why AI won't replace traditional EHRs entirely, but will instead develop and enhance them. It's a partnership, not a replacement.
A partnership. I think that's the healthiest way to look at it. We're still the clinicians. We hold the relationship, the context, the intuition. The technology is a tool to support that work, to clear away the administrative debris so we can be more present and effective in the room. It helps us overcome some of those persistent challenges, like the high cost and the steep learning curve of some of these massive EHR systems.
Right. For a small practice, shelling out tens of thousands of dollars for an enterprise-level EHR is just not feasible. But a more affordable, cloud-based solution that focuses on doing one or two things really well, like documentation, is much more accessible. It's about finding the right tool for the job.
And providing comprehensive training. So much of the resistance to new tools comes from being thrown into the deep end without a life raft. When you feel incompetent or slow because of a tool, you're naturally going to resent it. But if it's designed with the user, the clinician at the center, and if you're given the support to learn it, the resistance fades.
It really does. So when we look at the whole arc, from clay tablets and papyrus scrolls through filing cabinets and punch cards to the high-tech boom and now the dawn of AI, it's really a story about trying to solve the same core problem over and over again with better and better tools.
Yeah, the main drive has always been about providing better care. And for us in mental health, that means simplifying things so we can focus on the client. It's about making collaboration easier, making our clinics run smoother, and most importantly, protecting our own well-being so we can continue to do this work sustainably.
Well said. So as we wrap up, what's one practical takeaway for clinicians listening today who might be feeling that documentation fatigue, that EHR burnout?
I think for me, the takeaway is to reevaluate your relationship with your documentation tools. Don't just accept that it has to be a painful, time-consuming process. Get curious. Explore the newer, more intelligent tools that are being designed specifically for us. Your time and your clinical energy are your most valuable resources. The goal should be to find a system that honors that instead of drains it.
I love that. It's about reclaiming your time and energy. And if you want support in doing that, especially in turning your session conversations into clear, compliant notes without the hours of typing, the Mentalyc AI Note Taker is designed to do exactly that.